Dr. Gorge Bakris for an update on diabetic nephropathy, sir.
Well, thank you very much. It's a distinct pleasure to be here. I want to thank the organizers for putting this together. And this is one of the few towns in India I have not been in. So it's a very charming town. I really like it a lot. If you haven't been to the Mahatma Gandhi Museum, you should go. It was quite an experience yesterday. Anyway, let's talk about where diabetic nephropathy is and where we're going. And I have some information that may shock you as we go along, but hopefully you'll be able to keep up. So this is projections. This is from the IDEC website, and it's projections of where diabetes is going to be in 2040. And if you look over by Southeast Asia, you can see that the numbers are going to almost double by 2040, which is not that far away, actually. And of course, this is true from around the world. This is a major problem. And of course, obesity is a major problem, which is tracking with this. Now, if we look about some data, this is a recent paper that talks about the kidney per se. And basically, almost all outcome data that we have in people with diabetic kidney disease, with diabetic nephropathy, not diabetic kidney disease. Now, somebody could say, what are you talking about? And so what's the difference between diabetic nephropathy and diabetic kidney disease? And you could argue it's semantics, but there is a fundamental difference. And if you have evidence of kidney disease and you have diabetes, you have diabetic kidney disease for most practical purposes. But diabetic nephropathy, by the original definition, going back to the 1960s with Mogensen and Parving, you needed eye disease, you needed retinopathy. And basically, diabetic nephropathy is the continuum of diabetic kidney disease that has not properly been taken care of in terms of the multiple risk factors that you were just hearing about in the previous talks. So diabetes is the #1 cause of people going on to dialysis in the world, and that's true in every place, including China, where IgA nephropathy is very common, but diabetes is still #1. Now you'll notice here the trends, and this is coming from the US, things have leveled off a little bit, and I'll show you some optimistic data in a second, but I think it's important for you to understand that this is a huge problem, and look at the difference. That brown line is hypertension. 30 years ago, hypertension was the most common cause of people going on to dialysis. So you can see how things have shifted. And you can also see that, and I don't know if you can see it in the back, I apologize, but that very top line that's kind of a bluish green, those are the people that are 75 years old and older. So not only are people living longer, but they're living long enough to go on dialysis if they haven't really had a good experience with diabetes and managing it earlier in their lives. So there's been a couple of recent papers. These just got published in Diabetes Care, and I was privileged enough to write the editorial on this, looking at all of these studies going back to the 1950s. And what's gratifying about this in type 1 diabetes is that if you were born after 1980, because of the advances in management of hypertension, diabetes, et cetera, you have a 40% less chance of going on to dialysis than you would have if you were born before 1980. So clearly, there have been advances that are slowing progression of kidney disease without any question. And if you look at it more carefully, and you're more aggressive earlier in the course, you can probably die before you see the dialysis machine, which has really now been the nephrologist's goal, is to have you have a cardiovascular death before you go on dialysis. Now, what are the issues? Because the old teaching was microalbuminuria is diabetic kidney disease. Is that true? The answer is no, it's not. Let's take a look at the history of this data very quickly. What you see here is the original paper that put microalbuminuria on the map, and I just want to walk you through it briefly to make the point. I don't know if you can see it in the back, but there's a band here, and if you're above this band, it indicates mesangial cell expansion. Now, the mesangial expansion in the kidney is the earliest sign of diabetic kidney disease, in fact, even earlier than basement membrane thickening. So, important to note. Now, there are 3 groups in this study, and this is a biopsy study going out 5 years in people with type 1 diabetes. And everybody above this line has mesangial expansion. Now, this group is normotensive and normoalbuminuric. This group has microalbuminuria but is normotensive, and this group is hypertensive and has microalbuminuria. So these 5 patients form the basis for microalbuminuria being early diabetic kidney disease. Now, that was 1989, and so as we move forward, the authors themselves challenged themselves and went back, and in 2005, published another paper, again a biopsy study, again following albuminuria out to see if they could actually predict the trajectory of albuminuria with diabetic nephropathy, and they concluded there are 4 different patterns of microalbuminuria, and they have no idea which one is the correct one to predict diabetic kidney disease, so they then retracted their statement that microalbuminuria is early diabetic nephropathy, and basically said that it's a marker of some type of problem going on in the kidney. Okay, then we went farther, because by that time, everybody was putting ACE inhibitors in the drinking water, thinking you were going to stop diabetic kidney disease, and that couldn't be farther from the truth. So what these authors did is challenge that notion, and they set up a study in type 1 diabetes again, randomized, double-blind, double-dummy. It had all the perfect, if you were doing a test, this has everything in it that's perfect. And they randomized people, and they also did biopsies, and they looked at the eyes. And what they did is they randomized people to enalapril, 20 milligrams once a day, losartan, 100 milligrams once a day, or placebo. And then they stratified by center and gender. So there was no way you could get bias into this study. Well, mesangial volume expansion was the same primary endpoint that they looked at, just like their previous studies. And unfortunately, I just want to show you here the demographics, 285 people. If you look at the bottom here, you can see they were clearly hyperfiltering and clearly normoalbuminuric. So no question about it, these were very early in the course of diabetes. Their glycemic control was very similar, and notice everybody was above 8. And their blood pressures were remarkably well controlled, and you can see everybody was between 110 and 120. Now, if you looked at microalbuminuria as the primary endpoint, then you would conclude that losartan causes kidney disease, and that enalapril is no different than placebo for slowing kidney disease. Now, we all know that's not true, because there's a lot better data to support this, but nevertheless, if you were to believe the microalbuminuria story, that's what you would have had to have concluded. So clearly not indicative of progression of kidney disease, not at this very early stage for sure. And in fact, if you look at mesangial expansion, there was very good proof that neither losartan nor enalapril was any better than placebo in terms of changing the natural history. So this study, which was published in 2009, since then, there's been backpedaling to get ACE inhibitors and ARBs out of the drinking water if you're normotensive and have diabetes, because it doesn't change the natural history. Now you're going to say, wait a minute, that's type 1 diabetes. Well, that's true, it is. But that's the conclusion that I just told you. But there's studies in type 2 diabetes, and this study was done in the Pima Indians, and this is a 6-year plus study that did the exact same thing that Maurer did, except this time they looked not only at people with normoalbuminuria, they looked at people with microalbuminuria, and they randomized to placebo or losartan. And again, I've highlighted for you here the blood pressures, so you can see that they're normal, and the GFRs, you can see they're hyperfiltering, and the baseline levels of albuminuria, so you can see that one clearly had microalbuminuria, the other one didn't. And there was no difference in this study going out over 6+ years in anything regarding hemoglobin A1C, blood pressure, or GFR. And yet, when you look at mesangial expansion again, the primary endpoint in this study, If you got losartan and you were normal albuminiuric, it didn't change anything. It was exactly the same as what you saw in the type 1 diabetic. If you had microalbuminuria, it looks like there's a trend to improve things, but again, not statistically significant. So the bottom line is, in this kind of preventive notion that ACEs and ARBs are going to help you early, very early in the course, there's no evidence that that's actually true, at least over 5 or 6 years. Now, I didn't talk about the eye, but I will tell you that looking at the fundi, ACE inhibitors in that setting did reduce the risk of retinopathy, and they directly work through VEGF mechanisms. And in the type 2s, they didn't carefully do that exam in this study, but there's no reason to think mechanistically that it would be any different. So if you think about microalbuminuria, don't think kidney disease immediately. What you should be thinking about is inflammation. Microalbuminuria is the kidney's CRP. It is an indicator of a number of different diseases or different processes going on at the vasculature to indicate inflammatory responses. And a number of things can influence this, including cholesterol management, including, and as you know, glycemic control. So certainly other inflammatory diseases can actually increase albuminuria. So it's all very important to keep in mind from a context standpoint that if you've done it, so people have said, well, why should you even measure it? Well, the reason to measure it is because if you do everything right, you control glycemia, you control blood pressure, you control lipids, you've done all this, we know from the steno, and you've done a very good job, and you realize now that microalbuminuria has gone from 50 to 200 in spite of all this, then you've missed something. There's something else going on, or there may be that 15 to 20% of people with diabetes that have another kidney disease. So this is the reason to measure albuminuria, not that you're changing natural history by changing that. So I think that's the important point. Now, there are trials early on that were done to try to look at microalbuminuria and using it as a surrogate for kidney disease progression. And in all of these studies, there was a failure of the group that had the lowest reduction, or the greatest reduction in microalbuminuria, had the lowest level of microalbuminuria with intervention. They did the worst in terms of renal outcomes. So one has to be very careful in terms of looking at this as some marker that you've changed natural history. You haven't really done that directly as you may think. Now, if we then go to diabetic nephropathy, these are people that have 300 milligrams or more of albumin in the urine. Their GFRs are always below 60, so they're far more advanced. If you reduce that level of albuminuria, the data is very consistent that you are slowing progression of kidney disease, and I've summarized the trials for you here, but you need to have at least a 30 to 35% reduction in proteinuria. Now, I want you to know, you can't just give these people ACE inhibitors or ARBs and think you're done, because if you don't educate them and they don't follow a low sodium diet, you might as well throw it in the toilet, because those drugs are not going to work in people consuming high amounts of salt. So it's very important to also know that high salt increases proteinuria even more. And that's a whole separate lecture, but I think you need to appreciate the fact that this is not just drug related, this is patient education related. You have to talk to the patients and explain to them the importance of a low sodium diet, because if you don't, you're not going to get good results, and then you're going to wonder, well, what good is the data? The data is no good if you don't follow the lifestyle modifications, which these trials all did. So I think that's important. The other thing is, if you get worried about changes in creatinine, or if you get worried about potassium rising a little bit with an ACE or an ARB, I'm not talking about hyperkalemia now, but I'm talking about potassiums around 4.7, 4.8, then you better think twice, because if you don't give this group of patients with advanced nephropathy an ACE or an ARB, you're not going to slow their disease progression, even if you do lower blood pressure. And there are two prospective studies that show this very nicely, where proteinuria actually increased, even though blood pressure decreased. And so you really didn't help the kidney. So I think it's important for you to understand the distinction here of what we're talking about. Now, if we look at guidelines, we know that RAS blockers, I mean, this is in both the ACC, AHA, so these are cardiologists, and the ADA. RAS blockers are not recommended for normotensive diabetics. They're not recommended for people that are normoalbuminuric. And for microalbuminuria, if they're hypertensive, you can use them, but you don't have to use them. However, if you have more than 300 milligrams of albumin in the urine, you have to use an ACE or an ARB. Otherwise, you really will not be slowing kidney disease progression. And this is just an extension of what I just said, and that's the last part of it. So I'm just spelling it out for you so you understand that the old thinking of everybody has to be on an ACE or an ARB is not true. If you have diabetic nephropathy, you must be on an ACE or an ARB at all costs, unless you can't tolerate it. Earlier stages of disease, it's about glucose control, it's about blood pressure control, and if you want to use an ACE or an ARB, you can, but you're not getting an additional benefit. I think that's the point. Now, this is the world literature on diabetic kidney disease and progression of diabetic nephropathy, and you can see there's not too many studies really on a relative basis. And in fact, if you look at this from what is affectionately called the heat map, the stages of kidney disease and albuminuria, I just want to make the point again that this high albuminuria is microalbuminuria, and this is greater than 300 milligrams, as you can see here. If you're anywhere in the red here, anywhere, you're in very deep trouble, because not only do you have kidney disease and you're going to progress, but your cardiovascular risk is very high. So that's a very important point. Notice here, if you have microalbuminuria and your GFR is above 60, you're in the yellow range here, which means caution. It simply means you need to check it once a year and take care of the risk factors. That's really the message here. So the studies I just showed you, where do they end up on this map? They end up in that square. So if you want to be evidence-based, that's what we know. And the reason that is because you need to have progression of kidney disease understood at a short time frame, because it's very expensive to do these studies, and you're not going to get a signal for years if you intervene at a much earlier level. So this is the reason why this is where we are. Now the guidelines, I'm going to talk more about this afternoon, but the guidelines in terms of blood pressure pretty uniformly say less than 130/80, and ostensibly that's kind of where everybody is around the world. And I'm going to finesse that for you later, but I just want to point the picture out that if you actually look at the achieved blood pressures from clinical trials, the achieved blood pressures, what you have here is a relationship. I've got the studies over here you can see in terms of diabetes, but this has also got non-diabetes studies. So anything that's filled in is diabetes, and if it's a square, they have more than 300 milligrams of protein, and if it's a circle, it's less than 300 milligrams of protein. But you'll notice there that nobody is below 130. Everybody talks about a goal of less than 130, but nobody's below 130. Most people are between 130 and around 142. And what you see here, this little, if you can see it in the back, that little dash, that's the normal rate of decline in kidney function. It's about 0.8 to 1 ml per minute per year. And this X represents what the rate of decline in kidney function was in the mid-1980s, before we had a lot of these interventions. So we have made major inroads in slowing progression of kidney disease, and I showed you that data, the epidemiology data earlier, about people doing better if they were born after 1980. But we have not stopped progression of kidney disease, and in fact the average rate of decline is around 2 to 4 mLs per minute per year. We're in this neighborhood right here where a lot of these things add up. So we need to get over here. And that is a summary of all the epidemiology data put together with the clinical trial data, making it look a little better than it is, but still not if you have proteinuria. So What data do we have that actually randomized people to lower blood pressure so we know this? Well, in diabetes, we have nothing. We really don't. In non-diabetic kidney disease, we have 4 trials. And in all 4 of those trials, there was a failure to slow kidney disease progression if you were randomized to levels below 130. So there's no question anymore that for kidney disease progression, if you can get down to 130, you're in great shape. You do not need to be below that because you're not going to get additional benefit. You will get additional benefit on cardiovascular outcomes, but you will not for kidney outcomes. Now this is the SPRINT trial, and I'm just quickly showing you here that the aggressive group here looked at greater than a 30% decline in the eGFR. Now this is kind of a soft endpoint for the FDA. If that's positive, it shows you that something good probably is happening. But in this case, it was statistically significant, but unfortunately, there were many more events in the intensive blood pressure group than the regular blood pressure group. So, and that's a whole nother lecture too, that is not for you to say that you shouldn't aggressively control blood pressure. It's for you to understand that a lot of these patients float around with blood pressures that haven't been controlled for years. And now you jump in and control them, and all of a sudden their kidney is seeing lower pressures, and it responds accordingly to downshifting its GFR. And so that's not necessarily bad because there was a long-term follow-up of these people in the paper that was just published suggesting that 90% of them returned to baseline kidney function over the span of 6 months. So I think it's important not to immediately accuse these blood pressure controls and ACEs and ARBs of causing AKI, because that's not what this is. And in fact, there's no evidence at all of any tubular damage. That's another paper that's coming out. It's a renal hemodynamic adjustment to lower perfusion pressures. That's what this is. Now, this is the, in fact, here it is. I forgot I put this in because this just came out. But this is the data that I was just talking about, looking at the intensive arm and the standard arm. And again, they call this AKI because it was a 50% change in GFR that occurred within the span of less than a month after doing this. And you can see that most of the people here, if you actually look at this, were related to, most of these problems were related to dehydration or hypotension. Now, why am I telling you this? Because if there's one thing the kidney despises, it's a desert. It really, the kidney likes India because it's a humid climate. It needs to filter. It lives to filter. If you dehydrate yourself or you become hypotensive, that's the worst thing you can do for your kidney, and you will change kidney function very quickly if it can't adjust. So it's very important that hydration is maintained at all cost in these situations, or you will, especially at low perfusion pressures, cause these kinds of problems. And what happened, they rehydrated the patients, they got people's blood pressure up, they backed off on therapy, and kidney function improved. And in fact, here you go, 85% resolve within 3 to 6 weeks. Now, there are many people that are afraid of a change in GFR or a change in creatinine. And we published many years ago now, going on almost 20 years ago, the fact that if you get a rise in serum creatinine of up to 30%, don't worry about it as long as you don't have hyperkalemia, because things will be stable. A friend of mine actually put data together from his practice in people with diabetes and kidney disease. He's a nephrologist. And actually looked at these patients. You'll notice these are older patients, they're in their 60s. And you'll notice that it's not a huge group of patients. And the majority of them here have diabetes, and they're all hypertensive. And what you see here is on the left, all the patients, which are in the dark circles, and then the diabetic patients in the open circles. So you see the change going out over 10 years. But if you look to the right, the group that had a greater than 30% reduction in, greater than 30% increase in GFR, decrease in GFR, is plotted in the dark circles, and the open circles less than 30%. So you'll notice in the beginning it looks pretty bad. However, if you look at about 5 or 6 years, they come together. And so the reality is that you don't make things worse for the kidney. Nobody here developed hyperkalemia because appropriate diuretics were used in the setting. And nevertheless, these people didn't do necessarily better, but they certainly didn't do worse. So I think that's important for you to understand. And look at the slope of the decline in GFR over that 5-year or 6-year period in the group that didn't have a major change versus the slope of the people that did have a major change. So you'll notice there's a recovery kind of thing happening. And that's what happened in the other studies. And normally, that's what's going to happen. So you have to be patient and monitor the patient. Now, glycemic control. Can glycemic control slow nephropathy? Apparently, most people in this room thought that was true for centuries. Unfortunately, there was no evidence to support it until this long-term data from the ADVANCE trial came out. And you can see very clearly in the shaded box at the bottom that good, consistent glycemic control does slow kidney disease progression. Unfortunately, it takes 2 to 3 times longer to show it than it does for blood pressure. So again, back to the steno story, very important that you have to do all 3 things. It's not just blood pressure, it's not just glucose, it's not just lipids, it's everything done effectively and together. That's really the important point. Now, the VADT is another study totally focused on glucose. This is a post hoc analysis after 11 years. And you can see it took 8 years here to actually see a statistical difference based on glycemic control on progression of kidney disease. But nevertheless, it was there, and this is over 1,000 people. Now, you all know about EMPA-REG. I think the world knows about this very, very clearly. But the sub-study that was done looking at eGFR changes clearly showed stability, again, an immediate decline in GFR that you would expect to see with an ACE or an ARB. Now, these are pretty healthy kidneys. But then what happens is it stabilized and stayed like that, whereas the placebo group continued to decline. And so, in fact, when you actually do the math in that study, you've slowed progression down to 1.8 mLs per minute per year. Now, that's not a renally powered study. That's a sub-analysis of a cardiovascular study. CANVAS was another cardiovascular study, and it also did the same thing. It looked at renal endpoints, and this is data that were just presented at the National Kidney Foundation in Texas about a month ago. And here you can see that just like EMPA, the CANA group, and this is in the subgroup now in Canada that had kidney disease. Notice the GFR is 49. They had a small drop, and then again, if you follow them out, not only did it stabilize, kidney function stabilize, but it actually slightly got better compared to the placebo. Now, the real data is coming because there are a number of trials going on, one of which has been stopped because of futility. It'll be interesting to see what the data show because the trial did have at least 3 years of follow-up in it, and this is with an endothelin A receptor antagonist. And hopefully, if the data are all put together, any of you come to the kidney meetings in October, you'll maybe see this data. You'll certainly be reading about it somewhere in the literature within the next year. But the major problem here was volume overload. And any of you that know anything about endothelin antagonists know that they make minoxidil look benign in terms of fluid retention. And so this was a major issue. A lot of people had developed heart failure, so it was a tolerability thing. And even if it did turn out to be positive, it was going to be hard for a number of people to take it. There's a second study that is ongoing, will not be finished until late 2020, with a new non-steroidal mineralocorticoid receptor antagonist called finerenone. And this trial is ongoing. It's almost fully recruited. And again, primary renal outcome, and there's also a companion primary cardiovascular outcome study that are happening. And again, I don't think we're really going to know anything here until probably early 2021, but stay tuned. And then, of course, the Credence study. And the Credence study is the ongoing renal trial, which is in the last legs, hopefully at the latest, I'd say January of 2020, but probably in 2019, we may get the results of this. And if this is positive, This is really going to change and strengthen the whole issue about use of SGLT2s and slowing progression of kidney disease. If Canvas and EMPA-REG are any hint of what we're going to be seeing coming, this trial should be positive. We'll see, and remains to be seen what's going to happen there. And then lastly, there's the DAPA-CKD study. This is also going to be finishing around the same time, late 2019, early 2020, and that's with dapagliflozin, same kind of thing, and so we'll have to wait and see. This is Credence, just to give you an idea of what the design is like, and they're only looking at 100 milligrams of canagliflozin, and again, it's going to be looking at people with hemoglobin A1Cs of greater than or equal to 6.5 and less than 12, and GFRs at 30 up to 90, but the majority of these are going to be cut at 60. So, and everybody has albuminuria. Nobody's got microalbuminuria. It's greater than 300 up to 5,000. And everybody's going to be on a maxed out ACE or ARB. These are the baseline characteristics that were just published, and you can see that this is an obese group with a mean age of 63, and the mean GFR is 56, and they're right on the border of hypertension. So clearly, some exciting news, I think, coming down the pike. This will probably be the first to report amongst the SGLT2 studies. So, just to finish up, let me just make the point that diabetic nephropathy is a progressive form of diabetic kidney disease. Nephropathy, you got a great shot at making it to dialysis if you don't die first. So the whole point of this is aggressive metabolic intervention early on so that we can improve the outcomes. There's no data supporting RAS blockade in people with very early CKD, those with normal albuminuria or microalbuminuria, and certainly not in normal tensive patients. So you should not be using those agents in that setting. There's no data to support further renal slowing, renal progression slowing at levels below 130. However, there are data supporting reduction in cardiovascular events. And so I think it's important to keep both those in mind when you're treating somebody with kidney disease. I already told you the only place where RAS blockade has been proven is in advanced kidney disease, and that's not only for slowing progression of kidney disease, but that's also for reducing cardiovascular events. So I'll finish with that, and because I have to go do something else, instead of a panel discussion, I'm happy to take questions now if you have any, and we can discuss them. So thank you very much.
Thank you, Dr. Bakris. That was an excellent overview of diabetic nephropathy update. Any questions from the floor?
So George, thank you for an excellent lecture. Can you elaborate a little bit on the concept of normal albuminuria chronic kidney disease and diabetes? We're seeing a lot of patients. We don't know whether they previously had microalbuminuria or not. They are on RAS blockade. Their blood pressure is reasonable. It's not great, but reasonable. No proteinuria right now, and their kidney disease continues to progress.
Yes.
What's going on? Is it hypertension? Is there something else? When should we think about doing a kidney biopsy or something like that?
So this
I have one other question for you while I'm standing up.
Okay, yeah.
And that is one of the drugs that we tried for chronic kidney disease, which you know very well, is barloxolone, which actually showed, just like you've seen with the Cana, an improvement in GFR, and it turned out some of it was loss of muscle mass.
Right.
And there's one Japanese study with an SGLT2 inhibitor suggesting there may be some muscle breakdown loss as well. How much of that would play a role in the stabilization?
So the first, to your first question, before I came here, literally the day before I came here, there was a in-depth, high-level drug discovery, innovation, kidney disease conference in Boston. And it was mostly basic scientists. In fact, I was the only clinician there. And this is something that I put to the group because it was a who's who of nephrologists. And I said, you realize, of course, that while the renal literature may not have a lot of this, the endocrine literature is all over the place with this stuff. And how do you explain progression to dialysis without substantial albuminuria? We've been saying this for years, and now here's something that really doesn't fit.
It's actually quite common. The drug companies, including Bayer for Finero, which I'm involved in,
Yep.
are looking for people with proteinuria, and we see half my patients don't have proteinuria.
Right. So the issue is there's very little good data on this. There have been some case reports and biopsy studies that have been done. And it's interesting because if you look at those biopsies, they don't have the classic glomerulopathy that you see with diabetes. They have interstitial disease. And some people have said that there may be, and of course you got to understand now, I'm surrounded by geneticists at this basic science meeting, that there may be some kind of genetic mutation that's not protecting them from end-stage kidney disease, but changing the way the nephron is actually seeing the inflammatory response to diabetes, and that the podocyte injury is a later event, which is what's leading to the proteinuria, and the tubular interstitial disease is really what's starting things. And a lot of us think that a lot of those people have tubular interstitial disease that hasn't really been appreciated because not everybody's biopsying them. And if they did have that, what would you do about it? That's the real problem. So you're back to TGF-beta, TNF-alpha, and all that. Now, as far as bardoxolone goes, bardoxolone I think that, for example, in Alport's disease, bardoxolone's amazing. Now, that has nothing to do with diabetes, but the muscle wasting issue is something that, and again, it may be a dose-related phenomena. It is not a major, at least I haven't seen data, that it's a major change. Cystatin C hasn't changed, creatinine hasn't changed. So yes, there's been case reports on things like this, but it's unclear as to why that is. I think what's the sexiest thing about this, and I don't know, I hope it's going to be interesting how this turns out, is the whole thing about the sodium hydrogen pump in the heart and in the periphery and what have you, because at least EMPA has been shown to shut this thing down, so you get more of an acidotic pH, and you get an environment that actually, for the heart, it loves it because you're more acidotic. The heart can deal with ketones, it can deal with acid. But the periphery, if you have reduced circulation, not so friendly. So that may be a link to some of the things that we're seeing, but I think it's too early to tell.
Good morning.
Good morning.
We were just talking about DKD and DM.
Yes.
And the popular school of thought is to look at the risk factors like age, hypertension, hyperglycemia, and whatnot.
Right.
But there is another school of thought which are looking at susceptibility, initiators and progressors. Is it time that we put them together and look at those risk factors which are susceptible, initiators and progressors of diabetic kidney disease?
I think that those are the elements of the puzzle that need to be solved because it's obvious, and we've all seen this. I have people that and especially if they're African, you do everything humanly possible, they're moving along. They may move along slower, but they're still moving along. And then you have Caucasian patients, very similar characteristics. They'll be 10 years, 15 years, and then maybe they'll progress a little bit. Why is that? No one can give you an answer because nobody knows. But if you take that approach and come up with a couple of algorithms and tie some genetics to them, I think it would be really useful.
Why I want to bring this into this discussion is, when you look at dyslipidemia, hypertension and hyperglycemia takes the last seat. But when you look at these three, susceptibility, initiators and progressor, is hyperglycemia that makes a kidney susceptible, initiates a kidney disease and progresses kidney disease, whereas hypertension, susceptible and progressor, it may not initiate.
Well,
this is what I would like you to answer.
All right, so let me paint the picture for you because I'm not an endocrinologist, I'm a nephrologist, so I'm not glucocentric. And so I'm going to tell you that you have simultaneously burning three fires. You have the lipid fire, causing inflammation at the vascular level. You have hypertension fanning the flames and making things worse. And then you have hyperglycemia, which is adding gasoline to the fire. And so it's not that one is more important than the other. And the factors that are affecting injury are different in the eye than they're different in the kidney. VEGF is critical to the eye. VEGF in the kidney, not a big player. So each organ has their own little homeostasis, and you can't generalize that, TNF-R1 is the key, that's it, we know, because it doesn't work like that. And so we're still trying to get the general picture, and you're asking me to hone in on very specific things, and I know enough to tell you that it's not all the same, and they are going to be different. And if you only control, and we know this already, if you only control one risk factor or two risk factors, you're not going to do as well as if you control all three. And so, which one of those is the most important? I don't want to get into that argument, because as far as I'm concerned, that's like saying, well, I've put the fire out in one room of the house, but it's still burning over there, so I'm not worried about it. You can't take that approach. It's got to be all or none. Sure.
George, I have a question. It's very fashionable to do a microalbuminuria test in India because this has been pushed to such an extent, and from your lecture what I could make out was only if the dipstick is positive more than 300 milligrams, that is when the RAS blockade actually helps. So is it necessary at all to do a microalbuminuria in our patients?
So this is the point that I tried to make, and I'll make it again. I think it's very important at baseline, the first time you see the patient, it's very important to do a couple of things. Some of these are impractical, but they're very important. Number one, you should check to see if they have any level of albumin in the urine. That's very important. The second thing is, if you can, you should do a 24-hour blood pressure monitor so you can actually see what's going on. So microalbuminuria, if you don't know if it's there or not, then you're not going to pay attention to it. And as I was saying earlier, and as Vivian pointed out, there are people that are being treated and they're progressing, you just don't know. So albuminuria isn't going to tell you about 100% of the people, but it's going to tell you probably about 90%. And so if you don't measure it, you won't know what the change is. And if you assume that an ACE or an ARB is going to reduce it, well, you'll be right most of the time, but you're not going to be right all of the time. That's the important point. And as I pointed out earlier, you can be on an ACE or an ARB, and if the patient is not following a low sodium diet, you are not going to be able to reduce albuminuria.
No, because I asked this question because to do a microalbuminuria, it probably costs about $8 to $10. Just to insert a dipstick and check for proteinuria, probably it costs less than $50. So is it cost effective to do microalbuminuria, just a dipstick at every visit?
Well, the problem with dipsticks are they're very insensitive. So if the dipstick is positive, then you know you've got microalbuminuria. You probably have a lot more. You're only required to check it once a year. So it's not like you're going to do it at every visit. So I guess I would say for me, it may be worth doing it. In fact, they did a cost analysis. Now, they didn't do it in India, but they did do it in the US. If you have diabetes, or if you have diabetic kidney disease, or if you have hypertensive kidney disease with a GFR of less than 60, it is cost effective to actually check it once a year.
Dr. Vivian has a question.
So let me get into this argument a little bit.
Fine.
So I agree with you, George, that you won't know and it's worth testing till you become positive and you start the RAS blockade. The problem I have with the guideline is you got to continue doing it every year. What else do you do? You've already got the patient on a RAS blocker. You got the blood pressure reasonable. There's no other drug to give your patient. Yet the guideline says you got to keep doing microalbuminuria testing. I think it's a complete waste of money. I agree with our.
Okay, so let me, and I thought I said this, but maybe I didn't. If you have increases in albuminuria, you're on an ACE or an ARB, you've done everything, the patient swears they're being compliant, then for me, I would strongly consider doing a biopsy because you've missed something there. And if you wait too long, you're going to miss the whole thing. So, yeah, I mean, to a certain point, that's true. Or you can give an SGLT2. All right, I've got 20 seconds left, so thank you very much.